Hello, everyone. Thank you for joining so promptly and ahead of time. I will give everyone a couple more minutes to join us before we kick off. So yes, thank you all for being so prompt. But like I said, give everyone a couple more minutes and then we will jump in because we have a lot to cover and hopefully a really good session for you all. Thank you again to everyone for joining so promptly. I'm just going to give people another couple of minutes and we'll look to get started at 2:05 your time, 1:35 my time where I am. Right, giving everyone just one more minute for any latecomers, people caught up in a last minute meeting, phone call, and we will make a start. Alrighty, well, it is 2:05, so we've got a lot to cover, so let's make a start. And for those who haven't quite yet joined, they can watch the bits that they've missed out on via the recording that will come following the end of this. So I'd like to welcome you all to the joint PainChek and BestMed webinar on identifying pain, treating the person with integrated pain assessment for medication management. My name is Christelle Ucinek. I'm the Senior Commercial Manager for PainChek across Australia and New Zealand. I am a registered pharmacist by qualification that's worked in aged care for over 15 years, 9 of those in digital health, specialising in medication management and now pain management, where I've been part of advancing healthcare with innovative technology, strategic partnerships to improve resident outcomes. Now, before we begin, I would like to start by acknowledging the traditional owners of the land on which we meet today. For me in Adelaide, that is the Kaurna people, and pay my respects to their elders past and present, and extend that respect to other Aboriginal and Torres Strait Islander people who are present today on this call. So let's start with a macro view of what we know. Pain doesn't just impact people in residential aged care. It is a global problem. And when it's not adequately managed, it can impact so many things: cost, productivity, the broader healthcare ecosystem, but more importantly, the quality of life of the person in pain. We also know that we're currently facing the biggest influx of older people into our care, and more so that the number of people we support that will be living with dementia is on the rise. Now, on the right-hand side, there is an extract from the National Strategic Action Plan for Pain Management. And it states that more than 60% of people living with dementia are referred to the severe behavioural responsive team, have unidentified and undiagnosed pain. It goes on to say that as those with cognitive impairment are often unable to communicate their pain or identify the site of pain, their pain may be accessed through changes in behaviour, such as confusion, distress, restlessness, irritability, or aggression. Now, I just want that number to sit with you, 60%. It's big. And ask you to have a moment of self-reflection on your organisation's pain policy, practices, how you're monitoring, evidencing, and managing pain. With the technology and data and resources available to us today and into the future, do you think we can improve on that number? I think we can make a really good dent into it. So now, how does this impact you? I'm sure that for most of you, what's presented on the majority of this slide isn't new information. But I do want to take a moment to highlight that for the first time, the guidance given to care providers under the strengthened standards recognises pain as its own outcome, which raises expectations for proactive, consistent pain assessment and management, as well as referencing pain in 5.6 cognitive impairment and 5.7 palliative and end-of-life care. So what can this look like when we consider the practical application of how we do this in everyday care? And I will show you that in a case study to follow. But before we do, I'd like to call out the second point on this slide, the reference to the acronym NEMCF, which I assume will be new to most of you on this call. It stands for the National Electronic Medication Chart Framework. So I'm sure that you're all aware and familiar with the fact that BestMed as a medication management solution is conformant ENRMC. And you're all having the benefits of what that solution means and that conformance means across your day-to-day care, across prescribers, your staff, and more importantly, the residents. Now, to help align medication charts across the broader healthcare system, continue to improve upon safety and reduce risk associated with medications, there is current consultation happening on the next version of conformance and the framework that underpins that. That is the NEMCF, and it is supported by the Department of Health and the Digital Health Agency. Now, amongst those changes, the recording of pain scores for an individual in the medication chart will be mandatory. So in the back of your mind, and as we continue through the webinar, I want you to think about what impact, if any, this has on your current workflow across systems and at the point of care. And hopefully the reason behind the question is clearer as we progress. So I mentioned that we would look at how you can achieve proactive pain assessment, monitoring and management under the requirement of pain in the strengthened standards. And this is just one way a care provider has done it, but I'm sure there's many ways based on your priorities as an organisation where you can think about where pain impacts care delivery, wound management, reduction in falls risks, medication. There are many ways where pain impacts the day-to-day care you deliver. But before I go into this case study with Synovum Care Wynyard, I'd like to thank the team led by Yvonne Hunter, their General Manager, Karen Panzich, Clinical Nurse, and Sarah Panzich, their Registered Nurse, for their support and engaging in this work with us. And from my team, Diraj Bhawani, for collating these findings as the PainChek lead of customer insights for his work in mapping the data and bringing this all together. Without these people, I wouldn't be able to share these results with you. So Synovum Care is a 70-bed facility in the northwest of Tasmania. They use both PainChek and BestMed technology to support their care teams in managing the care needs of their residents. The decision to implement PainChek in 2022 was done to help improve pain practice. especially residents with complex needs that may not be able to reliably communicate their pain. In 2024, the team at St Novum Care went one step further to uplift and elevate their pain practices, and they did this as part of a continuous improvement activity. They introduced pain assessment as part of the Resident of the Day program, and in addition, focused on 100% utilisation of the auto analysis feature in PainChek. Now, for those of you who aren't familiar with the PainChek pain assessment tool, the facial analysis is the first domain of a holistic assessment that uses the AI to look for micro muscle movements indicative of pain in individuals living with cognitive impairment who express these facial features more prominently than those that are cognitively intact, like most of the people on this call. So with those two initiatives in place, the team wanted to measure what impact, if any, this is having on resident outcomes. Specifically, they wanted to look at the impact it had on prescribed medications and administration of those medications for pain and behaviours. So the data collected was done over a 6-month period from January to June in a comparative study from 2023 and 2024. The analysis over this period showed an increase in monthly assessments by 500%, which is a phenomenal result and outcome. It shows what is possible when we make it a focus. So when we look at the impact that had on medications, and specifically starting with regular medications, we saw a 54% reduction in regular opioid analgesic use. And that's by looking at the blue line on your slide. We also saw an 8% reduction in psychotropic medication administration, as displayed by the orange line on the slide. Now, if I bring my pharmacist lens to this, I immediately think about the impact this has on NQIP reporting, opioid stewardship, chemical restraint, and the potential to have an impact on polypharmacy. We all know that medications can have side effects and that those can be more pronounced in our older population. So in reducing the administration of these, we can be contributing to the quality of life of the resident. We also noted that with an increase in pain assessment frequency, we saw an 82% reduction in PRN opioid administration, another big number. And it's from looking at these results that we wanted to make these data-driven insights observed and repeatable by making this level of information more readily available, giving providers clearer visibility of what is happening across their homes and at an individual level. And this really started the conversation with our partners in BestMed about what was possible in strengthening our integration that's meaningful and makes a difference to our clients and the people we care for. So following these evidence-based outcomes, I think it's a great opportunity to hear and expand on these foundations presented and open this up to our panel for discussion. So just bear with me as I'm going to stop sharing and introduce the members of our panel. So I'm hoping that you all can see the members of our panel. Bear with me, because whilst I work for a tech company, not the most tech savvy person, and it's the first time I'm running a webinar. So I am just going to hope that you can see all of our people, and I can see Ben, but I cannot see, oh yeah, there we go, Ted and Dee as well. So I'd like to take this opportunity to introduce our panelists, and the first one I will start with is Dee-Anne Hull. She's a credentialed MMR and ACOP pharmacist, PSA dementia support pharmacist, and ACOP mentor in programs funded by Country SA PHN, providing specialised dementia medication management to those living within country South Australia. Dee champions multidisciplinary care, quality use of medicines, and improving outcomes through collaboration between healthcare teams, residents, clients, and their families. With experience in aged care, passion for equitable dementia care, it increases the advocacy work she does for this high-risk population and pharmacists wherever medicines are used. Next, I'd like to welcome Ted Fletcher. He brings a provider lens as the Manager of Quality and Compliance at OneCare. Ted brings over a decade of aged care experience, leading quality, governance and clinical improvement across residential and home care services in Tasmania. With a genuine passion for data-led decision-making and improving outcomes for older Australians. Couldn't think of a better person to have join us today with this background. And finally, but not last, Ben Kelland, Senior Product Manager at BestMed. Ben is a pharmacist by background and product leader with years of experience across digital health, aged care, pharmacy, and medication management. He specializes in translating complex clinical, regulatory, technical, and commercial requirements into safe, intuitive, and data-driven products to support clinicians at the point of care. So before we begin with our questions, to the audience, if there are any comments, questions for our panelists or otherwise, please feel free to submit them via the chat. And if there is time permitting, we'll do our best to get to some of those. So let's start with you, Dee. Your role as a dementia support pharmacist sounds fascinating and specialised, and it certainly caught my eye. And I was, really engaged to hear and have you tell me what that looked like. So are you able to explain to the rest of the audience and tell us what your role entails?
Yeah, definitely. Thanks for having me, everyone. It's great to be on the webinar. I've been very fortunate to be involved in a program that started back in 2024. We received funding through the Country South Australia Primary Health Network, which looks after 6 local health networks throughout Country SA, where we could design a program that supported people who are living with dementia. From any age, so childhood dementia right through to someone of a much older age, because we know that dementia can affect any age group. And throughout that, we've been able to provide not only specialised medication management support from a holistic perspective, looking through who is the person in front of us and what's going on for them, but we're able to support their care networks as well. So families and friends, and then the health professionals that also help to provide services for them. And we do that through education, advocacy. So it's been really exciting to be able to have a very broad program that means that we've been able to tailor it to each individual that we see. So yeah, it's been very exciting to be a part of.
Yeah, and it sounds like it's very rewarding as well, Dee.
It most certainly is.
Yeah. And I can only imagine, and I think I've said this before, we'd be so lucky to have more of you doing your role to play a part in those, waiting for that appointment or for that level of care to be seen by a specialist. So yeah, really great to have you on this panel, and thank you again. So moving on to Ted. Having worked in aged care for many years, what are the main challenges, if any, that you and care teams face when supporting the care of people living with dementia?
Yeah, so thank you. Thank you for the opportunity, obviously, to speak here on this panel. I think a lot of these won't come new to a lot of people in this room, but I think the biggest challenge we face is that pain and distress in people living with dementia doesn't always present in the most traditional ways. Many people can't verbalize it, they mask it, or they can't communicate it in a normal way. They can't a lot of the time come out and say, I'm in pain. And so you layer this then with the aged care environment, it's a fast-paced environment. And particularly in these rural places, we have a transient workforce. We have new people starting, we have people leaving, we have agency. And so what that leads to is we have staff who don't always get the opportunity to work with an older person and build that relationship over a long term and actually get to know and understand this person. We've also got aged care, which is extremely task orientated. Staff are busy, and this can unfortunately lead to small cues being missed. And I think that's where integration and pieces like this really come in. Having a really structured objective makes pain assessment so much easier. And then I think you have to overlay all of this and balance this with the documentation that we have to provide. And so we know what the Commission and our regulatory agencies request of us. And so it's this balancing game where we've always been told we need to document the care that you provide. I don't know how many times, whether it's ACOP, whether it's ANAC, we've been told this as nurses. But it's about finding that balance between providing great level care to the older people and then also documenting what we do. And so that's where I think integration and technology really come in and really kind of support us providing this level of care.
Yeah. And something that you said, Ted, just really resonates. And it's something that I commonly get asked for is that, or commonly have to respond to, should I say, is that we have very varying skills across our workforce. And so to be able to have tools, resources, supports built into technology or as a technology offering is really important to ensure that consistency of care, irrespective of the level of the workforce that we have on a day-to-day, which we know changes and is an ever-evolving issue across aged care and across healthcare more broadly. So yeah, I guess it's nice to hear that come from a provider as well, in terms of acknowledging that that is a potential barrier or something that you're having to deal with, and where technology can step in to support your care teams to do that. So and look, maybe just, I guess, diverting things a little, and this one's for you, Dee, is something that piqued my interest on LinkedIn was that you've been delivering an education series on deprescribing and dementia, which I think is amazing. And again, more broadly, I'd love it available to everyone outside of the Country SA PHN network. So what have been the common themes that you've encountered when you've delivered this to the audiences that attend those? And what impact do you think pain and medication management could have in appropriate prescribing?
Yeah, great questions. So it has been a high-risk medicines and deprescribing session that we've been running. It really looks at what are some of those more riskier medications, particularly in our older population, and why are they more risky? We know that people who are living with dementia have up to 4.6 times more chronic medical conditions than the wider population. So we know that there is significant polypharmacy and multimorbidity that's going with that, so more complex needs. But I guess a lot of the things that we've been finding is there's still that perception that in our older population that this person is still young and that they've got the same care goals as someone who might be in their 50s rather than someone who's in their 80s or 90s. So I think sometimes that the goals of care, that advanced care planning, sometimes that side of things is forgotten. Sometimes the targets for care are forgotten in terms of things. If we look at diabetes, for instance, we don't need to be as strict in our, I guess, not just the monitoring, but the targets that we're going for with our blood glucose levels in someone who's much older. We know that dementia is a terminal condition, so somebody is not going to get better. It is palliative in nature, so we need to look at deprescribing much earlier to support that good palliative care. Get rid of those medicines that are unsafe, potentially unnecessary anymore, to support that terminal phase of end of life.
And can I ask, from your experience, how open is the broader care team on taking up some of those recommendations, or their willingness to deprescribe? Because I know from my experience when I was on the front line, it was hard to convince GPs, especially, and prescribers more generally, to make that call and be willing to back themselves or have the evidence to support making that change and ceasing that medication. So what does that look like from your experience?
Yeah, there's definitely heaps of barriers, and that's something that we address in the workshop as well, is looking at what some of those barriers are and how we can potentially overcome them. A lot of it relates back to some prescribing habits. So, where a specialist might prescribe a medication, a GP might be a little bit more reluctant to change that medication because it came from the specialist. We also know that in aged care in particular, it might be that a doctor's inherited a resident that wasn't someone that they were looking after in the community. So sometimes there's that view of not wanting to change things that someone else has been involved in. Sometimes it's not that they don't want to deprescribe, it's not knowing how to. So through the work that we're doing, we provide quite a comprehensive deprescribing plan. And some of these medicines that we're looking at deprescribing, it can take 12 months to get rid of it if we want to do it properly, and we want to do it safely. So I guess time is probably one of the biggest factors in all of it, that deprescribing does take time.
Yeah, I think that's valuable. And I think it makes sense. And I also think to add to what you've just said is, it sounds like that potentially having some data to marry up to that bigger holistic understanding and to support those decisions sounds like it could actually really be helpful to the work you're doing, but even more generally how we approach medications and management of that more broadly for everyone. So I think with that mention of data, and look, taking a very simplistic view, Ted, we're looking at collating data in a meaningful way to make a difference to the care planning, to supporting decision making, but ultimately to get better outcomes. And so without seeing what the enhanced integration looks like, because we'll show you that a little later, what impact do you think having pain assessment and medication data can have for your residents and care teams?
Yeah, I mean, I think integration is the way of the future. It's where aged care is moving. And I'm honestly so excited. And I think we've got to try and start saying that being geeky and being nerdy is cool, because it's so exciting what we're going to get to do. I think for so long, information has been fragmented. It's been stored in multiple different systems. And so that just makes it difficult for everybody. It makes it difficult for staff. It makes it difficult for prescribers. And so I'm really excited, I guess, bringing pain assessment data into the medication system is hopefully going to paint this picture which is clearer, and it's going to streamline our decision making. I think from a care perspective, it's going to make it easier to understand what interventions we used, what medication was given, and whether it actually had a positive effect for this individual. I really hope that we're going to be able to see the effect of individualized medications and be able to support conversations around either increasing or changing medication or deprescribing, and having that really clear evidence for a prescriber to say, this isn't working, we need something else. I think it's going to promote better documentation. I think anywhere where you can build process into, or like policy into your process, is just a net benefit for everybody. We're also moving into this environment where, as a provider, we have to provide so much evidence back to the Commission and our regulators. And I think it's really going to help show our pain cycle and show that evidence that we've got. But I think most importantly, it's going to save us time. And I think before you all think it, I'm not suggesting we can cut hours here. That's not at all what I'm saying. The goal shouldn't be around saving dollars. The goal should be around saving time. And this is where I get really excited, is nursing and care is human interaction. And I think if we can use technology to save clinicians on administrative burden, we then create an opportunity where we get to spend time doing things systems can't. Imagine being able to reduce your administrative burden and spend more time sitting or talking with some other person, supporting someone with bereavement goals, or even just building memories and relationships. Like, this is where I get excited, is around how can we reduce our time on certain tasks and do more in other areas. And so that's probably what I think comes with this.
Yeah, and look, I'm happy to put my hand up and say I will join you as being that nerdy, geeky person, because I do believe that, I mean, without the technology, we wouldn't have the data that we have available at our fingertips, but the data and the insights and how it can lead to more personalized, tailored care, better evidencing to support your decisions, why you're doing things, to just help ease your care teams, provide better care. But, you know, when the Commission does come, you've got that data there, you've got that evidence. You don't have to look in multiple systems for it. I think, yeah, that really does excite me. And, you know, probably why I'm leading this conversation today, because it's something really close to my heart based on experience and being part of PainChek and being a pharmacist as well. Dee, I just wanted to ask you about an experience that you spoke to at a lunch and learn with the PainChek team more broadly. And I believe from memory, it was a palliative care example in supporting a doctor. And I was wondering if you could just share that with this audience, because I think it really helps to bring home potentially what this integration is going to mean in supporting care in that way.
Yeah, sure. So to start off, I first visited the client who was living at home, an 86-year-old female who was living with dementia, and she was living with her family at the time. She had quite a few difficulties with some behaviours and things like that, particularly, blowing up the microwave one night when she'd got up in the middle of the night to, cook something that she couldn't sort of remember how to do and those sorts of things. And we had discussions at the time about reducing some of those unnecessary medicines. At that time, she wasn't in that terminal phase of end-of-life care, but she was definitely starting to decline. So we spoke with the family about the options moving forward, and that it's okay if they could no longer manage her at home and she needed to seek residential care, that's a process that's okay to do. A lot of families have a lot of grief and difficulty sort of dealing with that burden of making those sorts of decisions. And it was probably about 6 months down the track that I came across this lady again, and she was actually living in residential aged care by that time. She was quite agitated, was trying to undo light globes in the facility, put blankets over lamps and things like that. So there were a few safety concerns. And again, they wanted a pharmacist input into what could be causing some of these behaviours and how could we help support that. Again, interventions were put in place. The facility said, you know what, I think we've got this under control now, so thanks for your help, but we'll manage things from here. Things progressed, and on one Wednesday morning, we got a phone call out of the blue from the Nightingale dementia nurses. So they are a group of nurses here in SA that provide specialised palliative care support, who said, you know what, this lady has deteriorated significantly. She now is in that end-of-life terminal phase, and she is severely agitated. What can we do? Like, we really need some support here. So that's where our team sort of got on board and went, like, what's actually happening for this person? And they had contacted the local GP who had been caring for this lady. It was about 10 a.m. and the doctor had said, I can't come till at least 5 p.m. today. You'll just have to manage it. And I sort of went, well, that's not actually good enough, because there's a lady here that is dying. She's severely agitated. It's really upsetting her family being part of this. But if this was my family member, they shouldn't be made to suffer. Like, nobody's family member should be made to suffer because the GP can't get there in time. So to me, it was like, well, you know what, we could get some subcut morphine charted straight away, and she could at least have that. She could have something in the meantime. During our discussions and having conversation with the GP was a junior doctor and had actually never really worked in the palliative care space before, had never initiated a syringe driver. So that was a big thing for them, was not so much not wanting to support this lady, but not knowing how to support the lady. So that's where we sort of talked through, got access to the medication chart from the nursing staff. What medications has she been having? What, pain relief does she need? So we worked out the morphine equivalents. We worked out how much midazolam she would need, how much metoclopramide she would need, and then discussed with the doctor how that could be charted and how that could be used in a syringe driver. The nurses themselves, very, very capable of using syringe drivers, something that they do quite often. So they just needed the meds charted. So we supported the doctor through charting those medicines. And then every day rang up to say what's been happening, how much PRN morphine has been used, how much PRN midazolam has been used, what are the equivalents. Contact the doctor again, right, based on the need in the last 24 hours, this is what we need to change the doses to. So we had about 3 or 4 days, I think, where we had to keep increasing the dose. The doctor is a bit reluctant with some of them, but the evidence was there in terms of the pain charting. And we actually got it to the point where this lady was actually comfortable for 3 days before she finally passed. So I think, to me, that was really important to be a part of that, and to know that the interventions that we had put in place actually supported her to have a peaceful transition in the end.
And I think that's a really powerful story and example of not only the work you do, but how all the information being stored in a single point to help communicate and help drive the decisions as to what's appropriate when someone needs it most is a really powerful thing. And so, yeah, thank you for sharing that story, because it's one that has stuck with me since you shared it with the team. And so I guess I want to, with all of this background and the input from Ted and Dee, now would like to move to Ben. I'm not ignoring you, Ben. Ben, and move to looking at the integration and then handing over to Ben to see what it is that we're actually going to achieve and announce. So Ben, to improve the integration, I understand that you actively engage with clients for their feedback on what's meaningful in terms of workflows and how pain assessment could look in the BestMed medication management system and what benefits it could have to them. So what was that feedback you received from providers?
Yeah, thanks, Christelle. So, yeah, we did. We met with numerous facilities and groups to define what the enhancement should be. So there's a lot of research that has gone into this. And, as has been mentioned a few times, pain is kind of it's inherently difficult to manage sometimes. And providers have sort of told us that when assessments, medication records and follow-up actions, they, all sit across sometimes different systems, it becomes harder for nurses to maintain a consistent workflow and for organizations to get a complete picture of what's happening as well. So what providers really responded to was the opportunity to bring pain assessment and medication administration closer together. So today, BestMed already has a read-only integration with PainChek, and where PainChek assessment scores are being pulled in as observations. And that was a really useful first step. But the desired future state is something more, like a workflow. And so the idea that is that when a nurse is administering a pain medication, they can be prompted to complete a pain assessment at that point in time, both, before and after administration. And that creates a much stronger clinical loop. So we're going to assess the pain, we're going to administer the medicine, and then reassess, whether the intervention was effective. And providers could see that this would support better clinical decision making, improve consistency for nursing staff, and give organisations a clearer view of pain management outcomes across their residents.
Yeah, perfect. And I think it does make a great segue. So I'm going to let you get prepared to sharing your screen. To hand over to Ben to kind of walk us through the prototype and an exclusive first look at the next enhancement in our integration partnership. It is using PainChek results and pain scores to validate PRN administration and measure effectiveness through reductions in pain scores, helping teams tailor medication approaches for more individualized outcomes. This level of integration is a first for PainChek, and it's something that excites me in that we're taking another step forward to person-centered care in understanding what works and what doesn't at an individual level. So over to you, Ben.
Great, thank you. Yes, I'm excited to give a quick little demo of what the enhancements are so centering around PRN administration. This is a little prototype I've built up here to demonstrate today. So we'll be familiar for those who use Best Dose. We come in here to a dose round, and we've got the PRN tab when we're needing to administer that or think we might. One of the components is that now it would be very easy to open PainChek. So if we'll also flag that, there hasn't been a recent PainChek assessment done, so that might be a good idea to do one. So when we click on the button, this is going to be just a deep link into the PainChek app, and it will also preload the resident at hand. So there'll be no double entry in between the systems. And then we can, assess the pain from the app and simply go back to Best Dose. So if the determination is made that, we do need to administer, we can use the existing functionality here in Best Dose to record the administration. And then we'll come down here, and now we start to see the record coming together. So we're going to link the PainChek assessment that we just did. So we'll confirm that one. And in BestDose, we then have a follow-up mechanism. So we want to try and get the effectiveness and what happened, the predetermined period after that. So when the notification is given in BestDose to do that, the nurse will come back in and be prompted to do the PainChek again. So we're going to get that follow-up. We're going to open up PainChek, assess the pain, come back, and then we can select the post-administration reading, and there's allowance for comments there as well if needed. And once we confirm that, we start to get the data, all linked here. It's all in the one system. So we've got the administration, the pre-reading, the post, and then historical reference as well here for the previous administrations.
And that's really exciting. And I think after all the work that the teams have done, it's great to see this prototype. But Ben, when is it going to be delivered?
So it is in development. I actually hope to have it as a real demo today, but we just didn't quite make it. But it's going to be released late July. So we're definitely getting towards the end there.
Yeah, that's amazing to hear that. Based on the work done to date, a release date is imminent. It's July. And I guess, knowing that this is coming potentially, and not to put you on the spot and not to hold you to account for what's about to come out of your mouth, Ben, but what could be the next step from having the PainChek data within the BestMed platform?
Another area providers have been interested in is how we can bring the data together at an organization level as well. And coincidentally, we have been working on BestMed IQ, which is our new reporting module, and is a massive uplift in the capabilities there. So the workflow integration is important at the point of care, but IQ hopefully will give providers a way to step back and see the broader picture. So provide a consolidated view of PainChek assessment data right alongside medication administration outcomes. So it could be at a facility level or an org level where we've got pain scores before and after, how often pain medicines are administered, whether follow-ups have occurred. And it's particularly valuable for larger providers because it moves the conversation from individual events to trends, governance, and quality improvement. And instead of it being in one system and then getting pain data out of the other, it's hopefully going to bring that into one system and put it all in the one spot.
Yeah, that's amazing. And like I said, I'm not going to hold you to it, but I look forward to, once we release this one, looking at what that means in the IQ part of BestMed. Look, I know there's questions in the chat, but I am conscious of time and there is one hand up. So I'm just going to quickly go to the person with their hand up. If you want to, RL Baker, raise your question, comment, feedback before we wrap up. Do I need to do something to enable that? There we go. Hopefully you can now join us. Oh, getting there. Nope. Lost that. Sorry. If you pop your question in the post in the chat, hopefully we'll get back to you. Now, to everyone that has put a comment or question in there, I will get back to you with a direct response, or make sure that the right person on the panel can get back to you. Hope you don't mind, panelists, if there's a question that is specifically for one of you, passing that on. And conscious of time, I just, before closing out this webinar, want to extend a sincere gratitude to Dee, Ted and Ben for taking time out of your days to participate in this conversation, giving us your insights around what pain assessment and medication management could do to transform care delivery. To the audience, thank you for joining us today. I hope this gives you a catalyst to reinvigorate some discussions on your pain practices, the impact of pain more broadly in care delivery, and that what we are offering is an opportunity to proactively manage the change that is coming with the NEMCF 4.0. Whilst this industry is undergoing significant change and pressures, we are all in this together. And I do hope that you feel our support as vendors to help make the delivery of high quality clinical care a little easier with evidence-led insights when using PainChek and BestMed. Thank you. Enjoy the rest of your afternoon. Bye, everyone.